All right, we're now in the second day of hearings, and we're at the Hospital Authority. So Jason, if you could introduce yourself, your colleagues, and then tell us how your year's been and talk a little bit about the status of your budget.
Okay. With me to my left, I have Mr. Bob Lonis. Bob is our Director of Finance and our interim Chief Financial Officer. And in the gallery behind us, we have Mr. Mark Overlock, who's our General Counsel. First of all, on behalf of the board and the medical staff and our little over 1,000 employees, we appreciate the opportunity to come down here today, and definitely appreciative of the relationship that we have with the city and the support that we've been given this year and in years past. And also like to thank our partners at Meharry Medical College, who provides most of our medical staff as the index teaching hospital for their school. It truly takes our partnership to do what we do every day. Over this past year, we've had some very challenging years, and this year was one, and next year will be another. I will say that, as the city hospital and a part of the safety net, we are meeting the mission and serving the needs of the community. This year we'll do about $89 million in uncompensated care, which is about 40% or so of our population that comes to the hospital. So that's really meeting the needs of the community here in Nashville and our surrounding areas. We think we've had a good year. We've accomplished a lot of things, even through challenging economic times, as the healthcare landscape is very uncertain. But we've made some good strides to better our position for the future. We finished another successful year of the Metro Employee Incentive Program, which, with your all's help, was able to set that up. That really nets us about $1.5 million a year, a gross revenue of about $4.5 million, about approximately 3,400 employees throughout the year. So we still see that as being successful and have some opportunity to expand that. We also, again, for the second year, were able to receive the public hospital supplemental funds, which tremendously helped us out, and we look for that to be able to happen next year again, which that will be the last year for that, so we'll have to do some work around that to ensure that can continue. Even on our long-term care campus, we were able to do some things to position us better, both fiscally and operationally. We reorganized, re-engineered some departments for savings of about $1 million, and also we're able to expand some key services like our chronic vent unit to 22 beds at the long-term care campus. Later on this year, we did a lot of work around our work-related injury program, and we see that as future benefit, not so much immediate impact, but in the first quarter of that program, we have seen some immediacy around that with a reduction in that of about 39%, so we feel that was very successful. We also, as we approach our meaningful use targets in terms of electronic medical records and electronic information systems at the hospital, again, with the help of the city, we're able to receive our first portion of that payment of about $1.6 million for this year. So, as we go forward, we see with the pending changes in healthcare reform and what that means for us, we've really started to look at how we must change with how the healthcare market changes. And recently, we're working with the group, Alvarez and Marsal, really to refocus and renew our strategic direction of what we need to look like and how we fit into this healthcare community here in Nashville. Because life as we know it in the healthcare field will significantly change one way or another in 2014. So that's really where we're focusing a lot of our efforts on. There's a lot of uncertainty from federal and state funding as well, whether it's through the TennCare programs. So that's, as we go forward for this next year, that's really where the bulk of our work will come around, is around what we have to look like in the future to be sustainable.
Okay, well, can you talk about, there are, I guess, two things, or there are multiple things that can happen, but one thing is that as we speak in April, of this year, there'll be arguments to the Supreme Court regarding the constitutionality of healthcare reform. And if that was to be found unconstitutional and you go back, I don't know where that would leave us. I guess you have to see the opinion as to how much would remain. But if there were some major ruling that overturned a portion of it, how would that affect you?
You know, there's a lot of unknowns. As if it goes through today somewhat as it's planned, I think about 250,000 people in Tennessee get added to the TennCare roster, roughly. You know, what we see as the biggest issue, regardless of if that happens or if it goes through as planned, is an access issue. I think it's more of an access issue than an insurance issue. You know, if our 40% of our population that doesn't have insurance all of a sudden have insurance, I still think you have access issues within the city. Now, if healthcare reform went through as planned today, from our perspective, I think we'd be a winner. You know, from some initial calculations, if all of our uncompensated population turned over and had funding from a TennCare perspective, we would be a net winner in that game. Now, if there's not a mandate around insurance, et cetera, then I still think you deal with portions of both. I think you have some that may be covered, and then you have some that still fall through the cracks and don't have access to insurance, affordable insurance, and similar to the patients that we serve today.
So in your analysis of your uncompensated, if they had access to TennCare, what's your analysis show that does to you financially? Have you done that level of analysis?
We did about a year ago, and basically if you took the uncompensated care dollars and ran that against, say, a TennCare fee schedule as it was, then it's at least a positive, you know, from an extent of, you know, if we're doing $89 million in uncompensated care from a cost basis, it's about a 50% cost to charge ratio. So that's about $45 million in cost. So if you ran that against a payer, say TennCare that was paying,
TennCare
it
would be
would
the
at least
one.
cover that.
It would cover that.
Right.
That's assuming those patients.
That's assuming.
Well, right. That's another level
that's
of
the
analysis.
variable
Right.
is that if they have access, would they go to general?
It's where the choice,
And
where the
that's-
choice.
So assuming they all
Yeah.
stayed at general, it's $45 million-ish in revenue.
That'd be about right.
Right.
About right? And what are the access issues I'm interested in hearing more about
You know,
that.
I think from a community perspective, I think it's access, not just at the hospital. I mean, we see across the community now, whether it's primary care physicians or other specialty physicians, many which are employed by other healthcare systems. Some don't take TennCare patients. Many are limiting their Medicare patients. So really, it gets down to, even if a person has the insurance card in hand, are they going to have a physician that they can get into? So I think going forward, the bigger issue is going to be access to that primary care, specialty care in the communities that we serve.
Okay.
What, can you talk a little bit about what the status of the relationship is with Meharry Medical College and Vanderbilt?
Okay. As you know, our management agreement with Vanderbilt ended December 31st. So the hospital authority is governing itself now through its board. Our relationship with Meharry still remains the same. We use Meharry through a physician service agreement for probably 99% of our physician component of the organization, and also serve as their index teaching hospital for their medical school. We support about 40 or so of their residents every year. That's not all of their residents. That's the portion that flow through our system as the index hospital. I think we have a good relationship. We've worked very hard on strengthening that and realizing the interdependency of the two organizations.
Okay. And can you talk about any cost-cutting measures you've taken this year or proposed for next year?
You know, as we go forward into next year, you know, a proposed 2% reduction is about $863,000 across the authority. And I mentioned a few of the things that we had done earlier, whether it's at Bordeaux where we've done some things we re-engineered the pharmacy component at Bordeaux for about $900,000. We restructured how our floors are at Bordeaux, which ultimately decreased our census, but increased our bottom line positively in that area. Also, we've been pretty stringently working on a productivity plan at the hospital for the past 6 or 7 months, which benchmarks us against community standards around our staffing and productivity and efficiency. And that's where a lot of our work takes place, and a lot of our work takes place in strengthening the revenue cycle to keep bills going out the door and cash, when appropriate, coming back into the organization, which I think we've done a very good job at that. That's where a primary component of our cost-cutting measures take place, really just refining existing processes, growing some services where appropriate in terms of trying to grow revenue with some specific physician services around urology, gastroenterology, surgical services. But on the expense side, it's really around operating efficiently and putting ourselves competitively against the private sector, which we ultimately have to compete with.
You've had, so in terms of the 2% reduction, you would be able to manage that?
You know, I think nobody wants to manage a reduction, but I think, it's something that we'd have to look at. I mean, we don't have specific plans in terms of our budget being put together that says this will mitigate that $860-some thousand. That's, the process that we're in right now. I mean, ultimately, it would involve some changes within our business model. Even if, and I will say that if we were getting a 10% increase or a 10% reduction, I mean, we still have to be fiscally responsible enough to look at all things regardless of what our cash position is. And that's what I think we've continued to do regardless of the financial situation, and say, is this businesses, service lines, et cetera, that we need to be in regardless of our cash position. And there are some other pending unknowns out there. We've seen some reduction from a state perspective this year, which really has to change our perspective on how we do business. And we've seen the trends change from an inpatient setting to more of an outpatient setting. So that really ripples through the business model of an acute care hospital and what we have to do to manage that.
What's happened to your revenue line, Jason, over the last couple of years?
And Bob, you might want to speak on this.
Yeah, overall revenues have been pretty steady. But again, as Jason was just saying, matter of fact, this year our inpatient is down significantly. Not just a local trend, but that's a national trend as well. Outpatient has actually got some growth, about 4% year to date. So that's really kind of the avenue and the niche.
What's your percentage between in and out, do you think, roughly?
Actually, outpatient today is probably about 55% of our total revenues. And that
Do you
didn't
see
use-
that trend going forward?
I do.
Continuing?
I
Yeah.
do. I do.
see that
As
continuing
we've
to
talked
grow.
about in other meetings, you've been struggling on census at the hospital this year.
Right.
And I don't think you're alone in that regard.
Right.
Yeah.
And again, the key about that is when we talk census is actually a statistic that relates to inpatients, but you've got a lot of patients that are occupying beds, but they're in observation beds, and that falls in your outpatient bucket. So in essence, you might have had 50 people in beds, but 12 might be observation, where in the old days, or previous years, those might have been 50 inpatients. So that's the kind of shift that's taken place. And so again, yeah, I mean, so, the numbers, when you look at pure inpatient statistic, patient days, they're definitely going down. But again, the outpatient continues to grow. This year overall, the gross revenues are down, but that's, again, because I think the inpatient bucket's kind of outdid the outpatient growth a little bit.
What is the census now?
We're running about 46 year to date.
And that
Again,
doesn't count
inpatient
the-
doesn't count the ops, like I was saying. So if you throw in the observation, we're probably looking at about 55 would be my guess.
And we've seen emergency department volumes grow, clinic volumes grow 12 to 15%. Just with the criteria that's out there now to meet inpatient status from managed care organizations, et cetera, they're not making it to the inpatient side. They're better suited, treated on the outpatient perspective.
Are you thinking strategically about the needs going forward as it relates to that trend to outpatient?
Right, and that's what we've been doing from when I mentioned an access perspective. I mean, the areas where we've seen the growth is around surgical services, our clinic perspective, cardiology services, GI services, and that's the needs that we're seeing from the community providers as well, whether it's the federally qualified health centers, is access to those specialty services. You know, even from our emergency room, how can those folks not be in the emergency room but be in our primary care medical home type setting? Because the volume of patients is increasing, they're just not meeting the criteria for inpatient status. So yeah, you really have to look at when your numbers on the inpatient side come down to that level, you really have to look at how to switch your mindset from operating from that perspective where you used to have fairly robust inpatient to where do I focus my energies on growing the outpatient from an access standpoint, because I think that's going to be your issue.
Okay. You've been, for, I guess, last year and this year, you've received additional funding that's going to be going away?
Correct. This next year in July will be the third year, which will be the last year on that waiver for access to those funds.
And what has that meant to the hospital in terms of the amount of money you're receiving and
Net amount, it's
This
about,
past year was 13.8 million, and we think that will be the same amount this July. It will be based on the same drawdown multiplier from the federal government.
and that ends because of what?
that ends because the length of term that was on that waiver to the 10-care
Right.
amendment.
Goes away.
An amendment waiver goes
And then,
away.
so you'll be you've had the advantage of having this additional funding, and that goes away. What preparations are you making for that?
Correct, and that's a large chunk of revenue that, you know, is catastrophic if that revenue stream just stops. We're doing the work kind of two-pronged. One, around seeing about the possibility of getting a renewal of that waiver to continue access for those funds as a part of the safety net. And then on the other side, you know, when I mentioned renewing our strategic direction and saying, what do we have to look like as an authority to deal with, you know, the financial realities that may come in the next 18 months.
And who makes the decision about the renewal of the waiver? Where does that come from?
Really, that's from a state perspective. It's a process that we would have to go through. You know, we participate in that waiver with the Med as well as a key component of that safety net. So we collaboratively work with them on trying to get that renewed. And it's a risk point because I know that, you know, federal matching of funds to states is under discussion and I think at risk as we go forward.
Okay. During the just looking at full-time employees or position totals, I mean, from '07 to the present, you've gone up by roughly, I don't know, 24 or so.
Okay.
And what's that attributable to?
You know, when we look at our productivity standards, we have standards by department. Is that an authority-wide number?
Yes.
Standards by department, and what we do is measure to that standard for those departments, and each year those standards change of what it takes to do a certain business. So it might say on X square feet of a facility requires X amount of facilities workers or housekeepers, et cetera, and that's what we try to manage to. Now, am I to sit here and say we're running at 100% efficiency? I don't think that would be a fair statement. I think we have some opportunity But the best we can, we staff to those standards.
Yeah, I mean, what I've got is you, in '07, you were at 1,192, then the peak was '08, 1,231, and then for the last 2 years, you've been at 1,218. Tell us about Bordeaux. What's the situation there?
One of the things we did last year, we consolidated some floors at Bordeaux. As you know, Bordeaux is about 95% TennCare population, largely ICF patients, so you don't have a large percentage of skilled patients. And so what that means is it's very difficult to cover your costs from a reimbursement standpoint on those patients.
Right.
We did some floor consolidation, which ultimately reduced our census by about 60, which probably yielded us $500,000 or so in terms of savings by doing that. Reorganized the pharmacy component, which I mentioned before, which was about a $900,000 a year savings. It's a tough environment. The long-term care environment is very tough. The reimbursement from the TennCare level is continuously under fire, and I don't see that getting any better. And Bordeaux's component of our subsidy is about $9 million. And we've done the things we could to try to stimulate some new revenue, like the vent unit partnership with Romeo. We leased some space to Kindred that runs a long-term acute care hospital within that setting. But revenue opportunities on the long-term care side are very difficult.
How many licensed beds there?
419.
What's the census now?
It's about 345, 350.
Yeah.
I mean, arguably, you lose money with each patient.
Right.
I mean, that's
That's the
what Jason,
problem with it.
what I think Jason is saying is that by cutting the floor down, you basically saved $500,000 because of the losses of those patients. And there's not the overriding
So it's not
demand
new
for it.
revenue, it's less expense.
Correct.
Right.
Yeah.
States put some caps on the revenue side.
Correct.
And so it made a business decision, which I think was clearly the right decision to make in terms of what you did at Bordeaux. I mean, do you have a waiting list at Bordeaux now? Is there a waiting list to get into Bordeaux?
What we've really done is really trying to manage our admissions, and that's it's challenging to do, but we felt from an economic survival perspective that's what we had to do, and we're still meeting the needs of that community and the patients that are there. But we had to make the choice to say, in order to keep doing what we do and do it well, we had to do that consolidation, and it's something that we have to look at going forward.
Okay.
There's some challenges there.
Yeah, I think, Mayor, you've hit on all the points that says that 2013, fiscal year 13, is going to be a sort of a critical year in which a lot of decisions on the future of all this have to be looked at. You've got healthcare reform, some
Correct.
form or fashion is going to
Right.
happen in 2014. You've got the probable loss of the federal supplement money, which is $14 million a year, which is critical. And I think, to their credit, the board and staff have seen this, have brought in an independent consultant who sort of has expertise in sort of turnaround and strategic positioning, and that's what this firm is worth looking on right now, and the Alvarez and Marcel group.
Correct.
And I think that sort of their thoughts and recommendations are going to be pretty critical as we look forward to sort of the long-term viability of this organization.
Okay. All right, well, thank you for your hard work, and I know you've got difficult jobs. It's exciting. You get to watch the news every day and see what's going to happen next. So
See what's next and keep our
Yeah.
fingers crossed.
I kind of thought, I actually thought I was reading the paper yesterday about what do they have, 3 days for argument?
Yeah.
This was probably the best case being made there for televising the Supreme Court. I mean, it would be a remarkable education experience for people if that had been available. But they didn't ask my opinion.
But we
I believe there's 9 votes on that.
Yeah.
Maybe just one.
And I don't have one.
You don't have one?
But I think, this education-wise of this issue that is obviously so important for the country, just to hear both sides of the arguments would have been remarkable.
There's a lot of unknowns, and it'll be interesting to see how it pans out. No matter which way it comes out, I mean, we know we definitely have to change what we look like. I mean, that's a given.
Okay. Good. Well, thank you. Appreciate y'all
Appreciate
coming
your
in.
time. Thank you.
Thanks for being here early.